Uh, I recently finished my orthopedics residency and have started my practice as an orthopedic surgeon in India. And today I'm going to explain about my research study, which I have finished during the course of my residency. My study is basically it's based on the frozen shoulder, adhesive capsulitis of shoulder. We have compared the treatment efficacy of only manipulation under general anesthesia and a combination of manipulation under general anesthesia with arthroscopic adhesive with subacromial decompression and rotator interval release. So first I would like to introduce my topic by explaining the basics about frozen shoulder, that is adhesive capsulitis of shoulder. Followed by that, I would like to explain how I have conducted my study and what were the outcomes of our study. So so first I would like to introduce it. So adhesive capsulitis is nothing but it's one of the most common shoulders benign disorders. Its etiology varies from post-traumatic to it is even associated with metabolic disorders like diabetes, hypothyroidism, and it may even be idiopathic. As for the other studies which have been conducted previously, various observational studies have been conducted on adhesive capsulitis of shoulder, and it has been observed that it is common among middle-aged, around 40 to 60 years, uh, and it is more age group, and it is more common among females when compared to males. So, according to many research studies, what it was noted is adhesive capsulitis is a self-limiting condition. Even without any treatment, it subsides with its natural history ranging from 9 months to 2 years. It will resolve by itself. But why do we want to treat it? We are trying to hasten the speed up the resolving process so that the patient's limitation, the period of limited activities are reduced further. So there many treatment protocols, many treatment strategies have been explained previously, ranging from non-invasive types like physiotherapy, only physiotherapy and manipulation under general anesthesia, to minimally invasive types like local infiltration of platelet-rich plasma, hyaluronic acid, steroid, or uh, arthroscopic adhesive or capsular release, which is also called as capsular release, or by just hydrodilatation by infusing the normal saline into the shoulder joint, which will further break all the adhesions. So, what do we mean by adhesive capsulitis basically? Adhesive capsulitis is nothing but in the shoulder joint, we have the shoulder capsule of the shoulder joint. The problem is there are many adhesions between the two layers of the capsule or in between the capsule of the shoulder joint and the humerus, head of the humerus, or any other structures such as superior and inferior glenohumeral ligaments and other structures which are present around the shoulder joint. These adhesions will restrict the movement of the shoulder joint. The most important thing which we have to remember here is the restriction is both active and passive. That is, even the active movements of the patients are restricted, and also when we try to move the shoulder passively, even those movements are also restricted. This feature is one of the most important diagnostic features which help us to differentiate adhesive capsulitis of the shoulder clinically from rotator cuff tears. In case of rotator cuff tears like supraspinatus tear or subscapularis tear or infraspinatus tear or teres minor tear, what will happen is the active movements are restricted. But if there is no arthritis of the shoulder, the passive movements will be normal. But in case of adhesive capsulitis, even the passive movements will also be affected. So this is one of the most important clinical feature which we have to keep in our mind when a patient with restricted active movement of the shoulder comes to our clinic. So in this study, what we have done is we have taken a group of primary idiopathic adhesive capsulitis of patients suffering from primary idiopathic adhesive capsulitis of shoulder, and we have compared the efficacy of manipulation under general anesthesia, only manipulation under general anesthesia, and a combination of arthroscopic capsular release with subacromial decompression, rotator interval release, and manipulation under general anesthesia. So how did we perform our study? So our study was a prospective interventional study. It was conducted from June 2018 to June 2020. The sample size of our study was 40 patients who were diagnosed with primary adhesive capsulitis of shoulder. So age group of our patients was between 30 to 60 years. As mentioned previously, it is the most common age group in which adhesive capsulitis occurs. All patients with comorbidities were excluded from our study. That's why it is called as primary adhesive capsulitis. The patients with comorbidities such as diabetes or hypothyroidism, which are one of the causative factors for the adhesive capsulitis, those were excluded. So patients were initially treated conservatively with analgesics and physiotherapy. We have followed a Dirkman protocol, and we have given analgesics and physiotherapy to the patients for a period of 6 months. We have observed and we have followed up the patients with analgesics and physiotherapy regularly. So after the 6 months, whoever the patients have not improved with conservative treatment, we have randomly allocated those patients into two groups. The first group received only MUGA, that is manipulation under general anesthesia, and the second group received the combination treatments. So the group 1 were treated with only MUGA, whereas group 2 were treated with a combination of arthroscopic release of the capsule with subacromial decompression, rotator interval release plus MUGA. So we had a group of 40 patients. So we have divided those 40 patients into two groups. One group contained 20 cases and the other group contained 20 cases. So before starting the procedure, we have measured the visual analog scale scores and also Oxford shoulder score. These acted as landmark so that we wanted to evaluate our patients after the treatment, whether the condition of the patient has improved or was it the same or it decreased or it worsened. So basically, the data was collected and it was analyzed with the XPSS software which we have used, and ANOVA tests were performed to compare the scores, outcome scores. We have used these scores, outcome scores, and we have compared these scores between the two groups. So this is the photograph which was taken while we were performing manipulation under general anesthesia in one of our patients. And this is how we have positioned the patient during arthroscopic adhesive, and these are the portals which we have taken for arthroscopic adhesive. So while performing the procedure, so what we have done is in case of arthroscopic adhesive, after positioning the patient in, we have positioned the patient in B chair position. Then after positioning the patient, after painting, scrubbing and draping, then we have introduced the scope, and here we have given some of the pictures where after breaking all the adhesions with the arthroscope and the shaver with burr, what we have done is we have removed all the excess tissue under the acromial process, so that there is no impingement to the rotator cuff. If there is any excessive decreased space in the subacromial process, in the subacromial space, there will be, for the rotator cuff to glide through the during shoulder movement, it will be difficult and the patient will be having restricted movement due to pain. So what we have done is, if the space is reduced, we have shaved off a little bit of acromial process, and so that the gliding movement of the rotator cuff through the subacromial space is not limited. And after that, we have also released a bit of rotator interval. And after this procedure, we have also performed manipulation under general anesthesia. So when coming to the results, most of the study population in our study were females. As we know that it is adhesive capsulitis of shoulder is more common among females. So, and we also noted that there is gender. In our study, we didn't have any association of gender with the outcome of the treatment. It is more frozen shoulder is more common among females, but the gender has no role in predicting the outcome of our treatment. And the second thing is, we have also observed that it is more common in the non-dominant side and rather than the dominant side. And also, we have also noticed that mean age of our patients was 47.95 years, that is 48 years. We have observed the pre-procedural and post-procedural mean, including both only manipulation under general anesthesia and combination treatments of visual analog scale and Oxford shoulder score at 1 week, 1 month, 3 months, and 6 months follow-up. So here in this table, we can see the table 1. It shows the comparison of the mean Oxford shoulder score and visual analog scale among both procedures. So it is the pre-procedural score. So what we see here is in the pre-procedural score, either it may be the manipulation under general anesthesia or ACR with subacromial decompression. There is not much difference in the Oxford shoulder score or visual analog scale. So it shows that the patients whom we had were equally distributed. It's not that it doesn't give a skewed presentation, so that leading to the skewed results. Whereas in the table 2, it shows the post-operative after the treatment at 3 months follow-up, however, the Oxford shoulder score and visual analog scale for these patients. So what we have observed is at 3 months follow-up, the mean Oxford shoulder score for Muga, only Muga is 34, whereas for arthroscopic capsular release with subacromial decompression is 24.35. So it shows that there is some significant difference between the Muga and ACR with SAD. Whereas for visual analog scale also, it shows significant difference of 1.94 to 0.47. So the in 3 months follow-up, what we have observed is the patients with arthroscopic capsular release with subacromial decompression and rotator interval release with Muga fared better when compared to only Muga. There were some chances of recurrences also in patients with Muga when compared with the arthroscopic capsular release. In table 3, we see the 6-month follow-up. In 6-month follow-up also, there is significant difference between Muga and arthroscopic capsular release. So now going to the discussion, in the treatment of a frozen shoulder, there are many strategies ranging from supervised neglect. Supervised neglect is nothing but we don't give any treatment to the patient. We just keep on following up the patient, but the disease takes its natural course and the patient will improve. To physiotherapy, only physiotherapy with analgesics. And there are some studies showing corticosteroid infiltration into the subacromial space or into the shoulder joint or to break the adhesions. And there are some studies showing manipulation under general anesthesia. And now, for example, in our study, we have compared the efficacy of Muga with arthroscopic capsular release. So there is no particular study showing that this is the best treatment for frozen shoulder or adhesive capsulitis. So there are many studies, each showing that one particular study has a good outcome, one particular treatment protocol fared better than the other. So based on all these researches, Dennis et al., he had done a research and among the healthcare specialists and revealed that in the painful phase, most professionals suggested non-operative treatment, including oral analgesia and physiotherapy. Most of them focused on professional experience and training rather than published research to choose the treatment. So what he has done is he had conducted a survey among the healthcare specialists, and he found out that among the healthcare specialists, these healthcare specialists, rather than following the research experience and training, they followed their own gut feeling that whichever whether non-conservative treatment or operative treatment, which they had to choose to their patients. So when we come to our treatment, Muga is comparatively straightforward to implement and it is time saving. So whereas arthroscopic capsular release is visually regulated, we can see the adhesions which we are breaking ourselves, but it is more challenging and it requires more expertise, and it is also time consuming, and it has its own unique dangers, such as chondrolysis might happen. We might, during arthroscopic surgery, we might damage the articular cartilage of the humeral head or the articular cartilage of the glenoid, so due to coagulation or thermal heat, there might also be some damage to the axillary nerve. In comparison, a combination of partial arthroscopic capsular release accompanied by gentle shoulder joint manipulation seems to be a secure alternative, as we have done in our study. It significantly lowers the dangers associated with Muga alone. In case of if we do only Muga to a patient with frozen shoulder, more force has to be applied over the shoulder joint to break the adhesions. And while we apply this amount of excessive force, we know that fracture shaft of humerus is one of the complication for Muga. So when we do arthroscopic release prior to Muga, it will be helpful as the adhesions are already broken. The Muga will be done with little resistance and not much pressure is required to move the shoulder joint, and the complication of fracture shaft humerus also reduces. For such a mixed treatment, a specific indication is not obvious, but it is recommended for most of the patients. Hence, our study helps in providing a statistical significance in comparing the efficacy of combination of arthroscopic capsular release with subacromial decompression, rotator interval release plus Muga, and only Muga in the management of primary adhesive capsulitis of shoulder. So I would like to conclude my presentation and my study. And the conclusion of my study was, at the end of the study, it is concluded that the combination of arthroscopic capsular release with subacromial decompression and rotator interval release, along with Muga, has a better outcome in comparison to only Muga in the treatment of shoulder primary adhesive capsulitis, which has not responded to 6 months of conservative treatment with analgesics and physiotherapy. So these are the findings of my own our own study which we had performed during my residency. So these are the references which I have collected, and thank you very much for this opportunity to allowing me to present my presentation in this conference. Thank you so much.